So, it might surprise you to learn just how much variability there is in something as fundamental as, well, your major abdominal blood vessels.
It really does vary quite a bit.
Yeah, like, for instance, the main artery feeding your upper abdominal organs, the celiac trunk. It has a pretty standard branching pattern most of the time, maybe around 75%.
Which is common, yes, but that still leaves a significant number of people, with unique arrangements.
Exactly. And get this, a single kidney can sometimes be supplied by not just one, but multiple renal arteries.
Yeah, the variations can be quite striking.
Okay, let's unpack this. Because today we're taking a fascinating look, sort of beneath the surface, into the world of vascular surgery, specifically focusing on how surgeons actually access those major arteries and veins deep within your abdomen.
And what's fascinating right from the start is this inherent variability in our basic anatomy. This deep dive into the surgical approaches, drawing on the knowledge in that comprehensive vascular surgery text. Yep. It really highlights a core principle. Surgeons must have not only, incredibly detailed knowledge, but also the readiness to adapt to the unexpected in each individual case.
Exactly. It's like knowing the map, but being prepared for detours, maybe alternate routes you didn't expect.
Precisely.
And for you, our listener, who's always seeking to be well-informed, this gives you a real appreciation for the incredible precision, the understanding required in these procedures.
It really does.
We'll be exploring the different roadmaps surgeons use, the challenges they run into, and those sort of aha moments when you see how all these vessels connect and interact.
Yeah.
Our goal is really to provide a clear, structured understanding, kind of extracting the key insights from these detailed chapters without getting totally lost in overwhelming detail.
And if we look at the bigger picture, understanding these surgical techniques reveals something quite profound about the human body, I think.
How so?
Well, it underscores the vascular system's remarkable ability to compensate through backup routes, what we call collateral pathways.
Right, those detours.
Exactly. And also how surgical methods are constantly being refined to address both the common and the unique anatomical landscapes we each possess.
So our mission today is to navigate this intricate anatomical terrain guided by the expertise within our source material.
Let's do it.
We'll start by charting the course of the major blood vessels, their typical paths, and the surprising variations they sometimes show.
Okay.
Then we'll explore the surgeon's toolbox, the different types of incisions they use to gain access.
The approaches, yeah.
And finally, we'll dive into the specific techniques used to expose individual arteries and veins. Ready to join us on this exploration?
Absolutely. Let's maybe start with the aorta's entry into the abdominal cavity. Where does it all begin?
All right, so the aorta, think of it as the body's main arterial superhighway, right? It enters the abdomen through an opening in the diaphragm.
The aortic hiatus.
Exactly, the aortic hiatus, which is located around the T12 vertebra, that's roughly at the level of your lowest rib. It passes through this opening, kind of nestled between the muscular bands of the diaphragm, the crura, just in front of your spine.
And the first few exits off this highway.
Good question. Those are the phrenic arteries. They branch out towards the front and sides, supplying the diaphragm itself.
Gotcha.
Then we arrive at the celiac axis. Now, this is a short but incredibly vital trunk that branches off the front of the aorta right as it passes through the diaphragm.
And this is where it gets anatomically complex, isn't it?
It really is. Here's where it gets really interesting. The area surrounding the celiac trunk is packed with this dense network of nerves called splanchnic ganglionic tissue.
Ah, yes, the celiac plexus area.
Think of it as a major control center for your abdominal organs. This can make a surgeon's work in this area a bit like, well, carefully navigating through a complex electrical junction box.
Yeah, that's a good analogy. And what's fascinating here is this close association between the major blood supply and the nervous control of the abdominal organs. It really emphasizes how intricately linked these systems are in regulating essential bodily functions.
And in most people, about 75% of the time, the celiac trunk acts as a very quick off-ramp. It splits into 3 main routes, usually just a centimeter or so from its origin.
Okay, the classic trifurcation.
Right. The splenic artery, heading towards the spleen, the common hepatic artery on its way to the liver, and the left gastric artery supplying the stomach.
Pretty standard.
Now, the common hepatic artery takes a slightly indirect route. It travels along the back wall of the lesser sac, that's a space behind the stomach, and it forms the lower border of a small opening called the foramen of Winslow, kind of a back door between different abdominal compartments.
Right, a key landmark.
It then follows the upper edge of the pancreas before branching off into the gastroduodenal artery and the proper hepatic artery.
So if we connect this to the bigger picture, understanding these spatial relationships is absolutely critical for surgeons, isn't it?
Absolutely.
The lesser sac, the foramen of Winslow, they act as key anatomical landmarks. They guide the dissection, help them avoid accidental injury to nearby organs.
Definitely. The proper hepatic artery then takes center stage, situated in front of the portal vein, and before it finally divides into the left and right hepatic arteries that supply the liver, it sends off a smaller branch called the right gastric artery. But as we hinted at earlier, there can be these anatomical variations.
It's the unexpected part.
Exactly, highlighting that principle. In around 18% of people, the right hepatic artery actually takes an alternate route and originates from the superior mesenteric artery, or SMA.
A replaced right hepatic, common variation.
And in about 12% of cases, the left hepatic artery does its own thing and branches off from the left gastric artery.
And these variations really underscore the importance of detailed preoperative imaging whenever possible, right?
Sure.
Knowing about these replaced arteries can significantly influence the surgical approach and help prevent, potential complications down the line.
Definitely. Okay, next up on our vascular journey, the superior mesenteric artery, or SMA.
Okay, the next major branch down.
This one emerges from the front of the aorta around the mid-L1 level, so just below the celiac.
Right.
It then travels downwards, passing behind the pancreas and crossing in front of the third and fourth parts of the duodenum, that's a section of your small intestine, before entering the root of the mesentery, which anchors the small bowel. The textbook notes that the origin of the SMA is often associated with some rather prominent lymphatic vessels.
Which can make the initial exposure a bit delicate. Needs careful handling.
Right. The SMA has several key branches, including the inferior pancreaticoduodenal artery, which cleverly connects with a branch from the celiac artery.
Forming that vital collateral loop between celiac and SMA.
Exactly, a crucial communication pathway. Then there are the jejunal branches, and interestingly, the first one is often spare in cases where the SMA is blocked by a blood clot and embolism.
Well, that's interesting. What's fascinating there is that detail about the first jejunal branch, often being spared in embolic blockages.
Yeah.
That's clinically significant because it can influence the extent of damage to the bowel and the potential for recovery.
Makes sense. Further down the line, we have the middle colic, right colic, and iliac arteries, all playing crucial roles in supplying different parts of your intestines.
The complex distribution system.
Now, the body is incredibly resourceful, isn't it? It has built-in backup systems in the form of these amazing collateral networks.
Absolutely vital.
There are crucial connections between the celiac trunk, the SMA, the inferior mesenteric artery, IMA, and even the internal iliac arteries down in the pelvis.
It's all interconnected.
For instance, the superior and inferior pancreaticoduodenal arteries link the celiac and SMA, like we said.
Right.
The SMA and IMA connect through the meandering mesenteric artery, also known as the arc of Reolin.
That's a big one.
And the marginal artery of Drummond. Think of these as vital detours on our arterial highway system.
And this emphasis on collateral networks is so important. It explains why a gradual blockage in one artery might not always lead to immediate tissue damage.
Because the body compensates.
Exactly. The body can often reroute blood flow through these alternative pathways, highlighting the inherent resilience of the vascular system. It's quite remarkable.
The meandering mesenteric artery is particularly interesting. It's a vessel that can actually enlarge significantly when the SMA is blocked, acting as a major detour.
A crucial backup.
However, it's located right at the base of the mesentery, and there's a risk of accidentally ligating it, tying it off, along with the inferior mesenteric vein when surgeons are working on the infrarenal aorta, the part below the kidneys.
Oh, that's a critical point.
Yeah. The text stresses the importance of being aware of this potential collateral circulation if there's a known blockage in the SMA or celiac arteries.
Or even after colon surgery.
Right. And also after any colon surgery, because accidentally cutting off the IMA when these collaterals aren't strong enough could lead to serious intestinal problems like ischemia.
This really highlights a critical surgical consideration. Understanding the potential downstream impact on blood flow when ligating vessels, especially when pre-existing conditions might rely on those vessels for backup support. You have to think ahead.
Definitely. Okay, moving a bit further down, we encounter the juxtarenal aorta.
So right around the kidneys now.
Exactly. This is defined as the segment of the aorta that's within about a centimeter above and below where the renal arteries branch off. So it often overlaps with the area where the visceral arteries emerge. The renal arteries themselves typically originate around the level of the first lumbar vertebra, L1, but the textbook emphasizes that there's considerable individual variation here.
Like we mentioned earlier.
Yeah, and as we touched on, up to 30% of people can have more than one renal artery on either side, multiple arteries feeding one kidney.
Which, again, requires careful identification during surgery.
For sure. And their position matters too. The left renal artery takes a path behind the left renal vein,
Posterior to the vein.
while the right renal artery travels behind the inferior vena cava, the IVC.
Posterior to the IVC on the right. This positional relationship is crucial during surgery, isn't it?
Absolutely.
Knowing that the left renal artery is posterior to the vein helps guide the dissection and avoid potential venous injury. And the reverse is true on the right side with the vena cava.
Continuing our descent, we reach the aortic bifurcation. This is where the aorta splits into the two common iliac arteries.
Usually around L4, L5 level.
Typically, yeah, L4, L5. And the inferior mesenteric artery, the IMA, usually branches off about 2 to 3 centimeters before this split.
Supplying the left colon and rectum.
Right. The IMA then gives rise to the left colic artery, a few sigmoid arteries, and the superior rectal artery. Now, the right common iliac artery has a specific relationship with the inferior vena cava. It runs right in front of it.
And in front of the origin of the left common iliac vein, too.
Exactly. Which means surgeons have to be extra careful when working around the origin of the right common iliac artery to avoid injuring those veins. They're very close.
That anatomical overlap significantly increases the risk of venous injury during arterial procedures in this area. It's a constant reminder that these vessels aren't just floating in space. They exist in very close proximity.
Very true. The textbook also points out that some branches of the splanchnic nerves, the ones providing sympathetic nerve supply to the pelvis, they run over the origin of the left common iliac artery. These need to be carefully preserved during open aortic surgery, particularly in male patients.
To avoid potential issues with ejaculation afterwards.
Exactly. It's a really important functional consideration.
Yeah.
And at the level where the iliac arteries split, each artery is crossed by the ureter, the tube carrying urine from the kidney to the bladder.
Another structure to watch out for.
Definitely. The text mentions that placing a ureteral stent before redo operations can help surgeons identify these structures more easily.
Good tip.
And during any surgery in this area, it's vital not to strip the ureter bare or place a prosthetic graft directly against it to avoid damaging its blood supply.
Right. Maintain that tissue plane.
Finally, one more structure. The cisterna chyli. It's part of your lymphatic system, collects lymph fluid. It sits behind and to the right of the aorta, and it passes under the right side of the diaphragm to enter the chest as the thoracic duct. Another structure surgeons need to be mindful of to avoid those tricky lymphatic leaks post-op.
And the detail about nerve preservation really highlights that vascular surgery isn't solely about restoring blood flow. It also involves minimizing the impact on other important bodily functions. It's a holistic approach.
Well said. Okay, so we've mapped out the major arterial and venous landscape of the abdomen. Pretty complex territory.
Indeed.
Now, let's shift gears and talk about the surgeon's toolkit, the different types of incisions they might use to access this intricate network.
The approaches themselves.
Right. The book emphasizes that vascular surgeons need to be proficient with a variety of approaches, really tailoring the incision to the specific surgical needs.
Makes sense. One size doesn't fit all here.
Exactly. The standard, maybe the most versatile option, is a transperitoneal exposure going through the abdominal lining via a midline incision.
So a vertical cut down the middle.
Yeah. Essentially a vertical cut down the middle of your abdomen.
And the midline incision's versatility comes from the fact that it provides access to almost every major artery and vein within the abdomen. It's kind of the workhorse incision for many different types of abdominal vascular procedures.
It is. However, it does have some potential drawbacks compared to other incisions, like transverse, which go across, or oblique, which are angled.
Such as?
Well, things like potentially more postoperative pain and a higher chance of developing an incisional hernia later on where tissue bulges through the surgical wound.
Ah, yes. Hernias can be a long-term issue.
Yeah, the text notes that the risk of this after aortic surgery with a midline incision can be as high as like 10% per year, which is pretty significant.
That is quite high.
Interestingly, though, there's growing evidence that placing a reinforcing mesh during the closure of a midline incision can actually reduce the incidence of these hernias after open aortic aneurysm repair.
Prophylactic mesh, right? That's becoming more common.
It seems so. It's an example of how surgical techniques evolve to improve patient outcomes over the long term.
And this trend towards considering prophylactic mesh placement really reflects the ongoing efforts in surgery to minimize long-term complications associated with the surgical access itself, not just the main repair.
Good point. Now, transverse and oblique retroperitoneal incisions, those going across or at an angle, approaching from the side, behind the abdominal lining.
For retroperitoneal approaches.
Right. They often result in less postoperative pain, which can be a significant benefit for patients with breathing difficulties, for example.
Less splinting, maybe better lung function post-op.
Could be. And they tend to have a lower rate of hernias, maybe somewhere in the 3% to 5% per year range, according to the text.
So some advantages there.
Definitely. However, they don't offer the same kind of wide-ranging access as a midline incision typically does, so it's often a trade-off.
Precisely. The choice of incision frequently involves carefully balancing the need for broad access with factors like postoperative comfort, the specific anatomical region you need to get to, and maybe the patient's overall condition.
Let's delve a little deeper into some of these incision types. The midline incision, as we said, incredibly versatile for working on the infrarenal aorta and its branches that's below the kidneys.
The most common area for aneurysm repair.
Right. It provides pretty much unrestricted access there. And by combining it with a technique called medial visceral rotation, which we'll explain later.
Moving the organs out of the way.
Exactly. It can even allow exposure to the suprarenal aorta, the part above the kidneys.
So very adaptable.
Yeah. The patient lies on their back, usually with one arm extended out to the side. The skin prep is quite extensive, often from the chest down to include both groins and mid-thighs.
Just in case you need access lower down, like the femoral arteries, or need saphenous vein for a bypass graft.
Yeah.
Always be prepared.
Right. The incision itself starts near the xiphoid process. That bony bit at the bottom of your sternum goes down around the belly button and can extend all the way to just above the pubic bone if the iliac vessels need exposure.
A long incision, potentially.
Can be. Once they're through the abdominal wall, the organs inside, the viscera, are carefully moved out of the way, packed into the lower abdomen if they're working higher up, or maybe over to the right side if they're focusing on the infrarenal aorta.
Gentle handling is key.
Absolutely. If the small bowel needs to be moved outside the abdominal cavity, it's usually placed in a special sterile bag to keep it warm and moist. Sometimes a moist towel is used as well.
Protecting the bowel.
And large mechanical retraction systems are really helpful here to gently hold the bowel aside and provide clear visibility for the surgeon.
Yeah, those self-rotating retractors make a huge difference. The detailed description of patient positioning and the careful handling of the abdominal organs really highlights the meticulous approach surgeons take to minimize complications and optimize their working environment.
Definitely. Okay, moving on to transverse and subcostal incisions. Transverse incisions, as the name implies, run across the abdomen, cutting through the abdominal muscles.
Horizontally.
Right. They can span from one side of the body to the other, depending on how much access is needed, roughly midway between the ribs and the hip bones.
Or sometimes just on one side.
Yeah, sometimes for more localized access, the incision might just be on one side, maybe ending around the midclavicular line on the opposite side. These transverse cuts can be either supraumbilical above the belly button, often described as a frown shape,
Upper abdomen access.
or infraumbilical below the belly button, like a smile.
Lower abdomen or pelvic access.
Exactly. The supraumbilical version is useful for accessing the infrarenal aorta, especially if there's also a need to work on the distal renal arteries. The infraumbilical incision is excellent for pelvic surgery, like dealing with large aneurysms in the iliac or hypogastric arteries, but it doesn't provide good access up to the perirenal aorta, that area right around the renal arteries.
So more limited superiorly.
Right. And there's some ongoing discussion, in the medical literature about whether transverse incisions genuinely lead to less pain, fewer lung complications like pneumonia, and fewer hernias compared to midline incisions.
Yeah, the evidence is a bit mixed, isn't it?
It seems so. Some studies suggest a benefit, others find no significant difference. It just reflects the complexity of comparing different surgical approaches and patient factors.
And this ongoing debate within the surgical community really highlights the challenges of definitively determining the optimal surgical access for every situation. There's a need for continued research to inform best practices for different patient scenarios.
Absolutely. Now, subcostal incisions are another type of transverse cut, but they're not as frequently used by vascular surgeons, according to the text.
Run along the rib cage margin.
Exactly. Parallel to and about 2 finger widths below the rib cage. The most common type is an extended incision on either the right or left side, starting near the opposite side's rectus sheath.
That tissue layer covering the six-pack muscles.
Right. Crossing the midline, extending as far as needed on the same side, usually towards the front of the armpit. These subcostal incisions are helpful for accessing the hepatic, liver, splenic, and renal arteries, as well as the veins in the upper abdomen.
So a more tailored approach for specific upper abdominal areas.
Precisely.
Yes, the subcostal approach is more targeted for specific regions in the upper abdomen, illustrating that principle of choosing the right tool, or in this case, incision for the specific anatomical challenge.
Okay, next up, we have the oblique flank incision.
Coming in from the side now.
Right. These are usually performed with an extraperitoneal dissection, meaning they go around the abdominal cavity lining, the peritoneum, rather than directly into it.
Retroperitoneal.
Exactly. A lift retroperitoneal flank incision made on the side is really useful for dealing with complex aortic anatomy, depending on which intercostal space the space between the ribs is used for the incision.
Higher or lower.
Surgeons can access different segments of the aorta, from near the diaphragm all the way down to where it splits, the bifurcation.
Pretty extensive access from the side.
It is. The main limitations are that it doesn't provide great access to the right iliac artery system or a good view of the right renal artery beyond its origin.
So better for the left side and central aorta.
Generally, yes. However, this approach is particularly helpful in certain situations, like redo aortic operations where there might be a lot of scarring inside the abdomen.
Avoids scarred territory.
Right, or problems with the suprarenal aorta, horseshoe kidneys where the kidneys are joined together, morbid obesity, inflammatory aneurysms, diastasis, that's separation of the abdominal wall muscles, and also in patients who have respiratory issues because it tends to cause less pain and interfere less with breathing mechanics post-op.
So several specific advantages in complex cases.
Seems so. The patient is positioned on their side, angled slightly towards their back, maybe 45 to 60 degrees. And the operating table might be bent or flexed to help widen the space between the ribs and the hip.
Opens up the flank.
Exactly. The incision itself starts on the side and can even be extended upwards between the ribs if more access higher up is needed. This is called a thoracoabdominal approach.
Combining chest and retroperitoneal access.
Yep. During the surgery, the tissue layers are carefully separated to create a plane behind the peritoneum, and organs like the spleen, the tail of the pancreas, and the left colon are gently moved forwards and towards the patient's right.
Mobilizing the left-sided structures.
Right. This dissection can be done either in front of or behind the left kidney. Behind the kidney, the retrorenal plane is generally a bit easier technically.
Okay.
A similar approach can be used on the right side to access the inferior vena cava. Shorter oblique incisions can also be used, but they offer very limited exposure.
So the retroperitoneal approach avoids entering the peritoneal cavity itself, which could be a significant advantage in certain circumstances. Like you said, redo surgeries with scar tissue, or maybe in patients where minimizing disturbance to the abdominal organs is desirable, perhaps less risk of bowel issues post-op.
Good point. Now we come to the thoracoabdominal incision.
Bridging the chest and abdomen now.
Exactly. This is used for accessing the upper abdominal aorta and the lower chest aorta, essentially bridging those two cavities. It's like an extended version of the retroperitoneal approach that goes up into the chest.
Requires managing the lung, potentially.
Yeah, for more extensive work on the chest aorta, a double lumen endotracheal tube might be used. That allows one lung to be deflated, giving the surgeon more room.
Single lung ventilation.
Right. But for less extensive exposure, a regular single lumen tube is often sufficient. The patient is positioned on their side, similar to the flank approach. The incision starts above the rib that needs to be accessed, curves downwards towards the midline, and usually ends at the edge of the left rectus sheath. The muscles are carefully separated, and the chest is entered through an appropriate intercostal space.
Between the ribs.
Yep. The lung is gently moved aside, packed away carefully, and the incision can be extended downwards into the upper abdomen if needed. This abdominal extension can be either behind the peritoneum,
Retroperitoneal again.
or by actually entering the peritoneal cavity and moving the organs, like with medial visceral rotation. The diaphragm, that crucial muscle for breathing,
Has to be divided.
it does, partially. It's carefully cut, usually along its edge, taking great care to avoid the phrenic nerve which controls it.
Very important to preserve that nerve function.
Absolutely. Sometimes a small piece of rib cartilage is removed where the ribs join the sternum to help with closure and maybe healing afterwards. Removing a small section of rib under the back muscles can also sometimes improve access and potentially reduce postoperative pain from rib retraction.
So, a major undertaking, this incision. The thoracoabdominal approach really highlights the close anatomical connection between the chest and the abdomen, allowing surgeons to address complex medical conditions that span both of these regions. Careful management of the diaphragm is obviously a key consideration in minimizing postoperative respiratory complications.
Definitely requires careful planning and execution. Finally, for accessing just the iliac arteries down in the lower abdomen or pelvis, lower quadrant incisions can be used.
More localized approach.
Right. The patient lies on their back, maybe with a small support placed under their side to tilt them slightly.
Yeah.
A common type is the hockey stick incision.
Shaped like one.
Kind of, yeah. It starts a little above and to the side of the pubic bone, curves upwards and outwards towards the edge of the rectus sheath, and then extends upwards along the side of that muscle.
Okay.
The layers of the abdominal wall are carefully cut, and the inferior epigastric vessels, small blood vessels in the way, are tied off. In men, the spermatic cord is preserved and gently moved aside, while in women, the round ligament can be sacrificed if necessary. A space behind the peritoneum, the retroperitoneal space, is carefully created, usually with gentle finger dissection.
Developing that plane.
Exactly. And the peritoneal sac containing the bowel and other organs is moved towards the midline to expose the iliac vessels lying underneath.
So, again, staying outside the main abdominal cavity.
Right, for this part. Shorter incisions just above the groin ligament, suprainguinal incisions, can also be used sometimes to gain control of the distal external iliac artery. This might be done if accessing the femoral artery directly in the groin is risky, maybe due to infection or a large pseudoaneurysm, a false aneurysm.
Providing proximal control in tricky situations. These more localized incisions demonstrate a focus on targeted access when the surgical need is confined to a specific area, thereby minimizing the overall invasiveness of the procedure compared to a full midline or flank incision.
Makes sense. Okay, so we've covered the various ways surgeons can gain access to the abdomen the main door's in. Now let's get into the specifics of exposing individual blood vessels. This is where the detailed anatomical knowledge really comes into play.
Absolutely. Where should we start? Infrarenal aorta.
Yeah, let's start there. The infrarenal abdominal aorta and iliac arteries using that common transperitoneal approach. The book describes this as the inframesocholic exposure.
Below the transverse colon's mesentery.
Exactly. And it's a very common technique. It can be performed through either a midline or a transverse incision. And it's often the preferred method when access to the right renal artery, the distal right iliac system, or maybe other organs within the abdomen is necessary.
Because it gives broad access.
Right. Once inside the abdomen, the transverse colon is lifted upwards and packed out of the way, usually superiorly, and the small bowel is moved over to the right side and protected, maybe in that moist bag we mentioned.
Clearing the field.
Sometimes the attachments of the third and fourth parts of the duodenum are divided, that's the Kocher maneuver, or part of it, and the duodenum is also moved over to the right.
Mobilizing the duodenum.
Then the tissue layer over the aorta, the retroperitoneum, is carefully opened, usually vertically. The inferior mesenteric vein, the IMV, is often the first major vein encountered higher up, near the duodenum, and it can be ligated and divided if needed to improve exposure. The aorta is then gently felt for, palpated, and carefully dissected free from the surrounding tissues.
Identifying the aorta itself.
The upper limit of this dissection is typically the left renal vein, which crosses over the aorta anteriorly.
A key landmark.
Absolutely. The text points out that this area, right over the aorta, contains numerous lymphatic channels. These should ideally be ligated, tied off with suture, or divided using something like an ultrasonic scalpel, rather than just cauterized or burned.
Why is that?
To prevent those troublesome chyle leaks after surgery. Cautery might not seal them effectively.
Okay. Avoiding lymphatic complication.
Right. The front of the aorta can be cleared down to where it branches, the bifurcation. The main vessel at risk of injury during this dissection lower down is the IMA, the inferior mesenteric artery.
Which comes off the front.
Yep. And this vessel has a network of nerves around it, the sympathetic plexus, which should be avoided if possible, especially in men, like we discussed.
Nerve preservation again.
Wow. And throughout this process, surgeons must be vigilant in identifying and protecting any large collateral vessels, like that meandering mesenteric artery we talked about earlier, which might be present and crucial if there's underlying disease.
The emphasis on meticulous lymphatic ligation highlights a common postoperative complication and the specific techniques used to minimize this risk. And additionally, The caution regarding the IMA and its surrounding nerves underscores the need for delicate dissection to avoid those unintended functional consequences.
Definitely. Now, for exposing the perirenal aorta, that segment right around the renal
A bit
arteries.
higher up.
Right. A more extensive mobilization of the left renal vein is usually required. Again, the surrounding lymphatic vessels need careful attention and ligation.
Okay.
The vein is freed from where it joins the vena cava, all the way past its major branches. The left adrenal vein coming in from above.
Superiorly.
The left gonadal vein, like the testicular or ovarian vein, coming from below.
Inferiorly.
And usually a lumbar branch that courses backwards and downwards posteriorly.
So freeing up those tributaries.
Exactly. By ligating and dividing these branches, the left renal vein can be gently retracted upwards or downwards as needed, usually using a soft rubber tube called a Penrose drain.
To get it out of the way.
Right. In some instances, the left renal vein might even be divided completely to achieve better access to the aorta behind it.
Really? Is that safe for the kidney?
Well, if this is done, its major branches must be preserved to ensure adequate venous drainage, adequate blood flow out of the left kidney through collateral pathways. If division is necessary, it should be done close to the vena cava to help maintain these collateral pathways.
I see.
There's some debate about whether ligating or dividing the left renal vein increases the risk of kidney problems long term, but most studies suggest only a temporary reduction in kidney function that typically resolves within a few weeks. Still, it's not done lightly.
Understandable. A potential risk to weigh.
Access to the origin of the left renal artery is achieved by dissecting behind the retracted or divided left renal vein. The right renal artery, remember, travels behind the vena cava,
Posterior to the IVC.
and its origin is visualized by freeing up the area where the left renal vein joins the IVC. Occasionally, small muscle fibers from the diaphragm's crust behind the renal arteries need to be released to improve visualization.
Cleaning up the space.
This dissection can extend as far up as the origin of the SMA if needed. And once again, any large crossing lymphatic vessels in this area need to be carefully ligated. If even more of the aorta higher up needs to be exposed, surgeons then have to access the lesser sac or use one of those retroperitoneal or thoracoabdominal approaches we discussed earlier.
The detailed steps involved in mobilizing the left renal vein illustrate the layered approach surgeons take. They access deeper structures while carefully safeguarding vital vessels and their tributaries. And that ongoing discussion surrounding left renal vein ligation highlights the continuous evaluation of surgical techniques and their potential effects on organ function. This is always evolving.
True. Okay, what about the iliac arteries further down? Their origins can be exposed by simply extending that retroperitoneal incision used for the infrarenal aorta a little further downwards, inferiorly.
Following the aorta down.
Right. This extension can even proceed along the right common iliac artery past its bifurcation to expose the entire right iliac system, the common external and internal iliac arteries on the right.
Pretty good access on the right.
Yeah. To visualize the right bifurcation and the hypogastric artery, that's another name for the internal iliac. The cecum, the beginning of the large intestine, and the small bowel need to be gently retracted over to the left side and upwards. At the level where the iliac artery splits, the surgeon must again be careful to identify and protect the ureter that crosses over it.
Avoiding the ureter.
The external iliac artery is exposed by making an incision in the peritoneum overlying it further down from the ureter. Now, exposure of the left common iliac artery is more limited with this standard approach.
Why is that?
Because the sigmoid colon is situated right above it, kind of in the way.
Oh, okay.
The text emphasizes again that the tissue crossing over the origin of the left common iliac artery contains those important sympathetic nerve fibers.
The hypogastric plexus.
Right, which should be carefully retracted rather than divided, particularly in sexually active men, to prevent potential issues with erectile function postoperatively.
Preserving function.
And another important point. Circumferential dissection going completely around the aortic bifurcation and the very proximal, the very beginning portions of the common iliac arteries should generally be avoided unless absolutely necessary.
Why is that? Too risky.
Yeah, due to the risk of damaging the underlying vena cava and iliac veins, which can be quite adherent, stuck to diseased arteries in this area, especially with aneurysms or plaque.
Ah, the thin-walled veins right behind the arteries.
Exactly. It's generally safer to gain control of the common iliac arteries a bit further distally where there's less risk of venous injury.
Makes sense. Control it where it's safer.
To access the left external and hypogastric internal iliac arteries, the sigmoid colon needs to be moved towards the midline after dividing its outer peritoneal attachment, mobilizing it.
Getting the sigmoid out of the way on the left.
Right. The external iliac artery then travels outwards and downwards along the psoas muscle to eventually become the common femoral artery in the groin. The dissection proceeds upwards along the external iliac to locate the iliac artery bifurcation and the point where the ureter crosses over. The hypogastric artery is identified as the large branch arising medially, heading down into the pelvis. Careful dissection is needed here to separate this artery from the iliac vein, which lies beneath it.
Again, avoiding the vein. The emphasis on preserving delicate nerve structures and the potential for venous injury in this entire region really underscore the critical need for precise anatomical knowledge and meticulous surgical technique. There's just no room for error.
Absolutely not. Now, let's quickly discuss the retroperitoneal approach for the infrarenal aorta and iliac arteries, specifically using that left flank approach we talked about.
Coming in from the side again.
Right. As we mentioned, this offers several advantages in certain situations. The oblique incision is made on the left side, as previously described. After entering the retroperitoneal space, the surgeon has to decide whether to expose the aorta anterior in front of or posterior behind the left kidney.
Two options for the plane of dissection relative to the kidney.
Exactly. The posterior approach, going behind the kidney, is more common. In this case, the left kidney and ureter are moved forward along with the peritoneum and its contents, like the spleen and colon.
Kidney comes forward with the other organs.
Right. When creating this space, it's important to remain anterior to the lumbodorsal fascia, that layer of connective tissue covering the back muscles, because disrupting it can lead to increased bleeding.
Stay in the right plane.
As the organs are retracted over to the patient's right, the aorta should become palpable. The initial focus is often on identifying the left renal artery, as this is a key structure potentially at risk with this approach.
Need to find and protect the renal artery first.
Locating it doesn't always require extensive dissection right around the pararenal aorta initially. A helpful landmark for finding this artery is a relatively large vein, the lumbar branch of the left renal vein.
That posterior branch we mentioned.
Exactly. It crosses the left side of the aorta at this level. This vein usually needs to be ligated and divided to expose the juxtarenal aorta properly.
Okay.
Now, if this lumbar vein is unusually large, it might indicate a retroaortic left renal vein, meaning the main renal vein passes behind the aorta instead of in front.
An anatomical variation.
Yep, a variation that would typically be identified on preoperative imaging like a CT scan. In such a case, the surgeon might abandon this retrorenal behind the kidney approach and switch to the anterior approach to avoid damaging this abnormally positioned vein.
Adapting the plan based on anatomy.
After dividing the lumbar branch, the left side of the aorta is dissected downwards towards the aortic bifurcation, being careful to identify the origin of the IMA. During the exposure of the bifurcation, the left ureter needs to be identified and protected as it crosses over the iliac vessels.
Protect the ureter again.
The entire left common iliac artery and its bifurcation can be visualized with this approach, but only the proximal portion of the right common iliac artery is easily accessible.
Limited view of the right side.
Right. Dividing the IMA can sometimes improve access to the right iliac artery, as can extending the incision across towards the midline, but accessing much beyond the right iliac bifurcation is rarely feasible with this purely left-sided approach.
So primarily for the aorta and left iliac. The retroperitoneal approach, with its different potential planes of dissection relative to the kidney, really illustrates how surgeons tailor their techniques based on anatomical variations, like that retroaortic vein, and the specific objectives of the surgery.
Good summary. Now, exposing the aorta anterior to the left kidney presents a greater technical challenge, according to the text.
Yeah, they're plain.
Right. It involves separating the kidney from the mesocolon, the fold of peritoneum attaching the colon to the back wall, and this often requires more sharp dissection with scissors or cautery, rather than just blunt finger dissection.
Trickier dissection.
As the left colon and other organs are moved anteriorly, the left kidney and ureter remain in their usual retroperitoneal position behind the dissection plane.
Kidney stays back this time.
Yep. The ureter must be carefully protected during the dissection of the left iliac artery as it crosses over it. Besides the scenario of a retroaortic left renal vein, the primary reason to choose this anterior approach is if a long segment of the proximal SMA needs to be exposed.
Why is that?
Because the SMA origin can be obscured by the crossing left renal artery when approached from behind the kidney. Going in front leaves the kidney back, potentially giving better access to the SMA origin.
Ah, okay. Trade-offs again.
As mentioned earlier, this approach, like the posterior one, has limitations in visualizing the distal right iliac system and the right renal artery. And it doesn't allow for a comprehensive exploration of the entire abdominal cavity like a midline incision does. However, a limited exploration can still be performed if needed by creating a small opening in the peritoneum that can be closed later.
The choice between anterior and posterior planes relative to the kidney highlights the surgeon's strategic decision-making, carefully weighing the need for exposure against the potential risks to surrounding anatomical structures, like the ureter or the adrenal gland.
Well put. Okay, let's move superiorly now and discuss exposing the proximal abdominal aorta, the part from the diaphragm down towards the renal arteries, using a transperitoneal approach through the lesser sac.
Going behind the stomach.
Exactly. The textbook indicates that this approach has somewhat limited application, as it only provides a view of about 4 to 5 centimeters of the aorta above the celiac artery, as well as the celiac axis itself and the very beginning of the SMA.
So not a huge length of aorta.
No, it's primarily used for things like visceral bypass procedures, rerouting blood flow to the gut arteries, and for gaining control of the aorta above the celiac artery when the lower aorta isn't suitable for clamping, maybe due to significant clots or plaque buildup, or in an emergency.
Supraceliac clamping.
Right. Either a midline or an upper transverse incision is used. The triangular ligament holding the left lobe of the liver is divided, and the left lobe is gently retracted over to the right.
Getting the liver out of the way.
Got to be careful not to injure the left hepatic vein during that retraction. The lesser sac is then entered by making a longitudinal incision in the gastrohepatic ligament, that thin membrane between the stomach and liver.
Okay.
Identifying the esophagus is made easier by the presence of a nasogastric tube, particularly in emergency situations. When dividing the gastrohepatic ligament, surgeons must be cautious not to cut an aberrant or replaced left hepatic artery.
Another variation to watch for.
Yep, which can be present in 10% to 15% of individuals. If present, it typically runs in the upper part of that ligament, usually originating from the left gastric artery. Needs to be preserved if possible.
Critical detail.
After retracting the esophagus and stomach over to the left, the right crus of the diaphragm, one of its muscular attachments to the spine, can be visualized. It's often elevated with a clamp and divided using electric cautery.
Dividing the crus.
The surgeon's finger can then be inserted between the aorta and the median arcuate ligament, which is a fibrous band crossing in front of the aorta. This ligament may need to be divided to fully expose the lowest part of the thoracic aorta as it comes through the diaphragm. Sometimes the chest cavity, the pleura, is inadvertently entered during this maneuver.
A potential complication.
The text emphasizes that circumferential dissection of the aorta at this high level is usually unnecessary for clamping and could potentially damage important posterior branches like intercostal arteries. Just clearing the front and sides is often enough.
Right. Get enough space for the clamp. The lesser sac approach offers focus access to the upper abdominal aorta and the main visceral artery origins, but its restricted field of view necessitates careful patient selection and a clear understanding of the surgical objectives, and awareness of potential vascular anomalies like that replaced left hepatic artery is absolutely paramount in this region.
Definitely. Now, in an emergency situation where rapid control of the aorta above the celiac is required, say, for massive bleeding lower down,
Time is critical.
absolutely. A quicker dissection is performed after entering the lesser sac. The avascular, clearer portion of the gastrohepatic ligament is incised. The esophagus is retracted quickly to the left, guided by that NG tube. The aorta is palpated, felt against the spine.
Locating by feel.
A finger is used to bluntly, quickly separate the aorta from the diaphragm's crura and surrounding tissues. Once a plane is established, the aorta is pinched between two fingers while a long vascular clamp is applied from the side.
Wow, that sounds intense.
It's a high-stakes maneuver demanding speed and precision under extreme pressure.
This rapid aortic control technique underscores the critical adaptations surgeons make in urgent situations to quickly secure blood flow and address life-threatening conditions. It's about immediate hemorrhage control.
Absolutely. Now, the celiac axis itself, if that's the target, is exposed by carefully dissecting away the celiac plexus, that dense network of nerves surrounding it.
We mentioned that earlier.
Yeah, this nerve tissue can be quite substantial and adherent, stuck to the aorta and the celiac artery. As the dissection proceeds distally outwards along the celiac trunk, the three main branches, splenic, hepatic, left gastric, are encountered and must be handled with care.
Why is that?
Because their walls are thinner compared to the main celiac trunk, making them more susceptible to injury from clamps or dissection.
More delicate.
Right. The SMA can usually be located just inferior to, just below, the celiac axis. By gently retracting the middle portion of the pancreas downwards, approximately 3 to 5 centimeters of the proximal SMA can be exposed using this lesser sac approach.
Limited SMA exposure here, too.
Yes. And again, the surrounding lymphatic vessels in this area require careful attention and ligation to prevent postoperative chyle leaks.
The meticulous dissection required for the celiac axis and its branches highlights the delicate nature of these vessels and the importance of avoiding injury to the surrounding neural structures as well.
Good point. Now, there's another method to access the entire proximal abdominal aorta, a different transabdominal approach known as medial visceral rotation.
Ah, yes, sometimes called the Maddox maneuver.
Exactly. This involves incising the peritoneum along the lateral aspect, the outer edge, of the descending and sigmoid colon, way over on the left side, and also along the spleen, extending the cut superiorly up towards the aortic hiatus.
Opening the white line of Tolkol.
Right. Then, primarily using blunt dissection, a space behind the peritoneum is created, and the spleen, the tail of the pancreas, and the entire left colon are mobilized interiorly, forwards, and over to the patient's right.
Sweeping everything from left to right.
Essentially, yes. The left kidney typically moves forward with these structures. The dissection plane is established behind the left kidney, anterior to the psoas and back muscles, again being careful not to disrupt that lumbodorsal fascia.
Okay, kidney comes forward.
As the left kidney is retracted superiorly, the origins of the celiac trunk, the SMA, and the entire left renal artery can be visualized quite well.
Good exposure to the origins.
However, access to the SMA beyond its initial few centimeters is limited by the crossing left renal artery, which is now stretched across the field.
Ah, the renal artery gets in the way of the distal SMA.
Right. In cases of a retroaortic left renal vein, or if more of the proximal SMA needs exposure, that alternative plane anterior to the kidney might be utilized instead.
Leaving the kidney back.
Exactly. With the kidney left in its normal position, a much longer segment of the SMA, maybe up to 8 to 10 centimeters, can be accessed. But then visualizing the left renal artery necessitates retracting the left renal vein.
Trade-offs again. Access one, obscure the other.
Seems so. Establishing this anterior plane is technically more challenging than the posterior plane, and care must be taken to avoid injury to the left adrenal gland and its draining veins, which are nearby.
More structures at risk.
Exposure of the aorta superior to the celiac is limited to just a few centimeters with this approach, and requires dividing the left crus of the diaphragm along the left side of the aorta, besides the inability to visualize the lower thoracic aorta easily.
What are the drawbacks?
Well, potential drawbacks include a higher risk of spleen injury during the mobilization, the text quotes up to 20%, and potential complications from excessive organ manipulation like bowel issues or pancreatitis.
So, not without risks.
No. However, when combined with standard transperitoneal techniques for the lower aorta, this medial visceral rotation approach offers arguably the greatest versatility for exposing the entire abdominal aorta and all of its major branches, from diaphragm to bifurcation, through one main incision type.
It's a powerful technique for extensive disease. Medial visceral rotation provides that broad access to the central abdominal vessels, but absolutely necessitates a thorough understanding of the regional anatomy and very careful surgical technique to minimize the risks of injury to those mobilized organs, especially the spleen and pancreas.
Very true. As we mentioned earlier, the proximal abdominal aorta can also be accessed via a left flank incision, going into the 10th or maybe 9th intercostal space.
The thoracoperitoneal approach again.
Right, depending on how far up you need to go. The 10th space is usually sufficient for clamping above the celiac artery and for accessing the perirenal region. But for procedures involving the visceral arteries themselves, like bypasses, the 9th space often provides better exposure, a better angle.
Higher up gives a better view downwards.
Seems to be the idea. When accessing through these intercostal spaces, the chest cavity is entered, so the diaphragm must be incised to prevent tearing when the ribs are retracted open.
Need to manage the diaphragm carefully.
Yes. An incision along the periphery, the outer edge of the diaphragm, leaving a 2 to 3 centimeter rim still attached to the chest wall, helps to avoid injury to the phrenic nerve and prevent paralysis of that side of the diaphragm post-op.
Preserving respiratory function.
Similar to the purely abdominal medial visceral rotation, the plane posterior to the left kidney is typically preferred for dissection. Dividing the left crus of the diaphragm longitudinally along the aorta improves visualization of the left renal artery origin and is essential for visualizing the origins of the celiac trunk and SMA from this angle.
Need to divide the crus for visceral artery origins.
And, as with the lesser sac approach, circumferential dissection of the aorta above the renal arteries is generally not necessary just for clamping, provided the anterior and posterior surfaces are sufficiently cleared to accommodate the clamp blades safely.
Just need enough room to get the clamp on securely. The Thoracoabdominal approach offers excellent proximal aortic exposure while carefully balancing the need for chest entry with minimizing postoperative respiratory complications through that meticulous diaphragm management and nerve preservation.
A complex but effective approach for high aortic work. Okay, let's now turn our attention to the specific exposures of the visceral arteries themselves. We've sort of touched on them, but let's consolidate.
Right, focusing on each main branch.
We've already discussed accessing the proximal celiac axis through the lesser sac.
Limited exposure there.
For the superior mesenteric artery, the SMA, the proximal portion, can be reached transperitoneally through the lesser sac, giving maybe 3 to 5 centimeters of exposure. Or via that medial visceral rotation technique we just described, or through a left flank retroperitoneal approach, which might offer 8 to 10 centimeters of the proximal SMA, depending on the plane used.
So, several options for the proximal SMA.
Right. Accessing the more distal portion of the SMA further down in the mesentery requires an inframesocholic approach.
Coming from below the colon.
Exactly. Through a transperitoneal incision, the transverse colon is lifted up and the small bowel is retracted down and to the right. The SMA is dissected out just to the right of the ligament of Treitz,
That suspensory ligament of the duodenum.
in the root of the mesentery, as it emerges from underneath the pancreas. In cases of SMA embolism, a blood clot blocking it, a pulse may still be palpable proximally, which can help guide the surgeon.
A helpful sign.
If not, an occluded SMA can usually be felt as a firm, cord-like, non-pulsatile structure. The superior mesenteric vein, the SMV, lies immediately to the SMA's right in this location.
Vein to the right, artery to the left. Standard relationship.
Using this inframesocholic approach, the SMA can typically be dissected from just proximal to where the middle colic artery branches off, distally down towards its ileocolic branches near the end.
So, good access to the mid and distal SMA here. The variety of surgical approaches to the SMA reflects its extensive course within the abdomen and the varying surgical needs depending on the location and nature of the vascular pathology, whether it's an embolism, stenosis, or aneurysm.
Good point. Now, for the hepatic arteries supplying the liver, an upper midline or an extended right subcostal incision is typically employed.
Access from the right side, mostly.
Yeah, elevating the right side of the patient slightly can be beneficial. The liver is retracted superiorly, upwards, and the right transverse colon and small bowel are retracted inferiorly, downwards.
Clearing the upper right quadrant.
The gastrohepatic ligament is divided and the lesser sac is entered. The common hepatic artery and the origin of the proper hepatic artery can usually be easily palpated, felt, within the hepatoduodenal ligament, that structure containing the portal triad running up to the liver.
Finding it by feel.
The common hepatic artery is dissected as it courses over the head of the pancreas and followed until the gastroduodenal artery branches off, usually downwards. Gentle traction on the common hepatic artery can help in visualizing these branches.
Putting it on slight stretch.
The proper hepatic artery is situated more distally, further up within the porta hepatis, the gate to the liver. It lies anterior to the portal vein and usually medial, or to the left, of the common bile duct.
The classic portal triad anatomy. Vein posterior, artery middle left, duct anterior right.
Exactly. And the textbook reminds us again about the potential presence of a replaced right hepatic artery originating from the SMA, which would run parallel and usually to the right of the portal vein in this area and requires careful identification and preservation.
Always watch for that variation. The detailed description of the hepatic artery exposure emphasizes the critical anatomical relationships between the artery, portal vein, and bile duct within the porta hepatis. It highlights the potential for serious iatrogenic injury to any of these structures during dissection if care isn't taken.
Very true. Accessing the splenic artery heading to the spleen can be achieved via an upper midline or an extended left subcostal incision, often with a support placed under the patient's left side to rotate them slightly.
Coming from the left this time.
The proximal segment of the splenic artery is best approached through the lesser sac. This can be entered either by dividing the gastrohepatic omentum superior to the stomach's lesser curvature,
Above the stomach.
or by dividing the gastrocolic ligament inferior to the stomach after elevating the greater omentum and transverse colon.
Below the stomach. 2 ways into the lesser sac.
Right. The posterior wall of the stomach is then separated from the pancreas, and the superior border of the pancreas is exposed. The splenic artery usually courses tortuously along the superior surface of the body and tail of the pancreas.
A winding path along the top of the pancreas.
For exposing the more distal portion of the splenic artery, closer to the spleen, a partial medial visceral rotation can be performed.
Similar to the full rotation.
Kind of, but maybe less extensive. The lateral peritoneal attachments of the descending colon are divided, and the left colon is retracted medially. The pancreas and spleen are then moved anteriorly and medially away from the left kidney, which remains in its normal position. The splenic artery can then be palpated and dissected along the superior border of the pancreas out towards the spleen.
Mobilizing the tail of the pancreas and spleen. The different surgical routes to the splenic artery illustrate the surgeon's adaptability in choosing the optimal approach based on the specific segment of the artery requiring access, proximal versus distal, and the surrounding anatomical constraints.
Good way to put it. Now for the renal arteries supplying the kidneys, as we discussed in the section on the pararenal aorta.
Around the kidney arteries?
The origins and initial few centimeters of the renal arteries can be exposed using that standard infrarenal approach through the midline or transverse incision.
Coming from the front, below the colon.
Right. The peritoneum over the aorta is incised. The duodenum is retracted to the right, kosher maneuver. The avascular plane beneath the pancreas is entered carefully. The left renal vein is mobilized.
Ligating its branches, adrenal, gonadal, lumbar.
Exactly. And then the vein can be retracted superiorly or inferiorly as needed. The left renal artery typically lies posterior to the vein. A portion of the left crus of the diaphragm might need to be divided to enhance exposure of the very origin.
Okay, left side is relatively straightforward there.
The origin of the right renal artery is exposed by mobilizing the confluence, the junction of the IVC and the left renal vein. Usually, 1 or 2 lumbar veins draining into the IVC posteriorly need ligation to allow medial retraction of the vena cava itself.
Moving the IVC slightly.
The left renal vein is then retracted superiorly, revealing the origin of the right renal artery coming off the aorta behind where the IVC was. Overlying lymphatic vessels may also need to be ligated here too.
Emphatics again.
And again, dividing a portion of the right crus of the diaphragm can be helpful here for visualizing the origin. The inframesocholic approach generally provides better, easier access to the left renal artery compared to the right.
Why is that?
Mostly because the IVC is sitting right in front of the right renal artery origin, obscuring the view somewhat.
Makes sense. The IVC is in the way on the right. The inframesocholic approach highlights the central role of the left renal vein as a crucial anatomical landmark in accessing both renal arteries, and the necessity to mobilize the IVC for right renal artery exposure underscores their close spatial relationship.
Definitely. As mentioned previously, the entire length of the left renal artery can be exposed through a complete medial visceral rotation,
Sweeping everything over.
or via a left flank retroperitoneal approach. The textbook cautions, though, that the left renal artery can be subjected to significant tension, stretched, when approached from behind the kidney using the retroperitoneal approach.
When the kidney is pulled forward.
Right, when the kidney is retracted anteriorly and medially. Consequently, any bypass grafts to the left renal artery performed in this position should always be created with some slack, some extra length,
Why?
to prevent kinking or tension on the graft when the kidney is returned to its normal position at the end of the surgery.
Ah, good practical point. Avoid graft problems.
Access to the right renal artery, particularly its middle to distal segment out towards the kidney, typically requires a right medial visceral rotation,
Mobilizing the right side now.
also known as the partial Cattell-Brash maneuver. This is performed through either a midline or transverse transperitoneal incision. The lateral peritoneal attachments of the ascending colon, from the cecum up to the hepatic flexure near the liver, are divided,
Opening the right gutter.
and the ascending colon is retracted medially, towards the left. The underlying second part of the duodenum and the head of the pancreas are mobilized medially using a Kocher maneuver
Lifting the duodenum and pancreas head off the IVC.
to expose the right kidney and the IVC. The right renal vein is then dissected circumferentially all the way around from its junction with the vena cava distally as needed, with ligation of any small tributary veins encountered. This vein can then be easily retracted up or down to facilitate dissection of the underlying right renal artery.
Getting the right renal vein out of the way.
The right renal artery courses posterior to the IDC to its origin from the aorta. Accessing its more proximal portion, near the aorta, necessitates mobilizing the IBC away from the midline, retracting it medially. Any lumbar veins encountered during this process should be ligated carefully on the vena cava side to prevent the ligatures from becoming dislodged during retraction.
Secure those lumbar veins well. The cattle-brash maneuver exemplifies a specific, named surgical technique designed to provide optimal exposure of structures in the right upper and mid-abdomen, including the right renal artery and the inferior vena cava itself. It's a standard mobilization technique.
Exactly. All right. We've dedicated a good amount of time to the arteries. Let's now turn our attention to the major abdominal veins, starting with the big one, the inferior vena cava, or IVC.
The body's largest vein.
The internal and external iliac veins down in the pelvis join at the sacroiliac joint to form the common iliac veins. The ureter, spermatic cord in men, round ligament in women, and the gonadal vessels all cross over the external iliac veins at this level.
Lots of structures crossing nearby.
At the point where the aorta and vena cava bifurcate, the iliac veins are very close to the posterior aspect, the back of the iliac arteries.
We mentioned that risk earlier.
Right. This proximity makes them susceptible to injury during rapid dissections of these arteries, particularly in trauma scenarios where things are moving fast.
High risk of venous injury there.
The IVC itself originates around the L5 vertebral level, usually just to the right of the midline, at the confluence, the joining of the common iliac veins. The aortic bifurcation is slightly more superior, higher up, and anterior, more forward, compared to this venous confluence.
So they aren't exactly side by side at the split.
No, the right common iliac artery crosses anterior to the IVC bifurcation and the origin of the left common iliac vein. The book notes that there can be significant adherence, scar tissue essentially, between the posterior wall of the aortic bifurcation and the anterior wall of the caval bifurcation and proximal iliac veins in this overlapping region.
Especially with inflammation or atherosclerosis.
Right, making dissection there particularly hazardous.
Very risky spot.
The infrarenal IVC, below the kidneys, receives 3 pairs of lumbar veins posteriorly, which kind of tether it to the psoas muscles in the back.
Need to ligate those for mobilization.
Exactly. The renal veins, typically single vessels on each side, enter the vena cava around the L1, L2 level. The retrohepatic IVC, the portion behind the liver,
The difficult area to access.
receives 3 large hepatic veins superiorly, draining the liver, and several smaller branches from the caudate lobe of the liver inferiorly. The IVC then enters the chest through the diaphragm at the T8 level and drains directly into the right atrium of the heart.
So a short path from liver to heart.
Yeah. Injury to the IVC can result in massive, life-threatening hemorrhage, underscoring the critical importance of a thorough understanding of its anatomy.
Absolutely critical.
And surgically relevant variations in venous anatomy exist too. Things like a left-sided vena cava, a duplicated IVC where there are 2.
Right.
A retroaortic left renal vein, which we've discussed, can impact arterial surgery, and rarely a circumaortic left renal vein where the vein splits and encircles the aorta before rejoining. All things surgeons need to be aware of.
The detailed anatomy of the IVC and its intricate relationships with surrounding structures, particularly the aorta and iliac vessels, highlights the delicate balance surgeons must maintain to avoid iatrogenic injury during vascular procedures in this region. And awareness of those congenital variations is also of paramount importance. You can't assume it's always textbook anatomy.
Very true. Several incisions can be utilized to expose the IVC below the liver, infrahepatic, and above the liver, suprahepatic, with the choice depending on the extent of the IVC requiring visualization.
Different levels need different approaches.
A midline transperitoneal incision is standard in trauma settings and is frequently employed for elective cases too. A right transverse Transperitoneal or a right flank retroperitoneal approach can also be useful, but might offer slightly more limited visualization of branches beyond the cabal bifurcation compared to a midline. A subcostal incision can also be used for more limited exposure higher up.
Midline offers the most versatility again.
Generally. With the transperitoneal approaches, the small bowel is retracted over to the left side, and a right medial visceral rotation is performed, as we described earlier, for renal artery exposure.
Mobilizing the right colon and duodenum.
Right. Following a Kocher maneuver, the head of the pancreas and the second and third parts of the duodenum are retracted to the left, exposing the IVC and the renal veins. This mobilization also allows dissection of the porta hepatis structures and the inferior aspect of the superior mesenteric vein posterior to the pancreas if needed.
Wide exposure of the central retroperitoneum.
This dissection can be extended superiorly to expose the retrohepatic vena cava, the part behind the liver. Some surgeons find that extending the incision into the ninth intercostal space on the right chest enhances visualization of the retrohepatic IVC even further.
Adding a thoracic component.
Division of the diaphragm can expose the segment of the IVC just below the heart, the juxta-atrial IVC, along with the major hepatic veins entering it. For more distal exposure, down to the iliac venous confluence where the IVC starts.
So we're down.
The peritoneal attachments of the cecum are divided, extending to its junction with the small intestine, and the entire right colon is retracted over to the left. This is the full Cattell-Brash maneuver we mentioned.
Mobilizing the whole right colon.
This approach allows visualization of the IVC all the way from the common iliac veins superiorly up to the caudate lobe of the liver. Even more extensive exposure, including the infrarenal aorta, if needed, can be achieved by dividing the retroperitoneal attachments of the small bowel mesentery from the right lower abdomen superiorly all the way up to the ligament of Treitz. And basically eviscerating, lifting out the entire small bowel and right colon from the abdominal cavity temporarily.
That's extensive mobilization.
It is. Ligation and division of the lumbar veins that tether the IVC allow for its mobilization, but it's recommended to place the ligatures securely on the IVC side of these branches to prevent inadvertent dislodgement during retraction.
Secure ties.
And one technique mentioned for rapidly exposing the IVC bifurcation and proximal iliac veins in a trauma setting, if there's a major injury there,
A specific trick.
is to temporarily divide the overlying right iliac artery to gain quick access to the venous injury underneath. Following repair of the vein, the artery is then reanastomosed, sewn back together to restore blood flow.
Sacrificing the artery temporarily for faster vein access. Interesting. The diverse surgical approaches to the IVC underscore the need for adaptability based on the level of injury or the extent of exposure required. And that trauma-specific technique of temporarily dividing the iliac artery for rapid IVC access highlights the critical decision-making under pressure in emergency situations. Sometimes you have to do something unconventional to save a life.
Exactly. Now, for accessing the parts of the IVC behind and above the liver, the retrohepatic and suprahepatic IVC.
Even more challenging.
Definitely. A midline approach extending into a median sternotomy division of the sternum, the breastbone is the most common incision, especially in trauma involving this area.
Opening the chest as well.
A chevron incision, that V-shaped upper abdominal incision sometimes combined with a sternotomy, or an incision through the 8th or 9th intercostal space on the right chest combined with an abdominal incision, thoracoabdominal, can provide excellent exposure in elective surgeries for tumors or complex reconstructions.
Different options for planned cases.
A transperitoneal approach is facilitated by elevating and retracting the edges of the rib cage laterally, opening things up. After entering the peritoneum, the right triangular ligament suspending the liver is divided, along with the other peritoneal attachments of the right lobe of the liver. The right lobe is then mobilized and retracted medially, towards the left and anteriorly forwards.
Rolling the liver over.
This reveals the retrohepatic IVC underneath. Several small veins draining the caudate lobe, and occasionally the posterior aspect of the right lobe, are encountered during this process and must be carefully ligated and divided to prevent tearing and troublesome bleeding.
Those small veins can be tricky.
Of the 3 main hepatic veins draining the bulk of the liver, only the right one can typically be reliably visualized just with this mobilization. Exposure of the other hepatic veins, middle and left, and the suprahepatic IVC, the portion right below the diaphragm, necessitates more extensive liver mobilization.
You need to free up the liver even more.
Right. The round and falciform ligaments connecting the liver to the front abdominal wall must be divided, And all the superior peritoneal attachments of the liver, the coronary ligaments, need to be incised to expose the bare area of the liver where it sits against the diaphragm. The liver is then retracted inferiorly downwards to visualize the suprahepatic IVC and the main hepatic veins entering it.
Extensive liver mobilization.
If obtaining control of the IVC between the hepatic veins and the diaphragm is proving challenging or impossible from below, intrapericardial control, getting control from within the sac surrounding the heart, can be achieved after performing that median sternotomy.
Going above the diaphragm, via the chest.
Exactly. Accessing the retrohepatic and suprahepatic IVC represents a complex surgical challenge due to their deep anatomical location and close proximity to vital organs like the liver and heart. These extensive surgical approaches underscore the severity of injuries or diseases in this region and the need for advanced surgical expertise, often involving teams of surgeons. Absolutely. Finally, let's briefly discuss exposing the portal vein and its main branches, the veins draining the gut and spleen that form the portal vein going to the liver.
The inflow system to the liver.
Right. The superior mesenteric vein, the SMV, lies to the right of the SMA within the root of the mesentery. It crosses anterior to the third part of the duodenum and the uncinate process of the pancreas, and passes posterior to the neck of the pancreas to join the splenic vein. The splenic vein runs in a groove along the posterior aspect, the backside, of the pancreas. The inferior mesenteric vein, IMV, lies to the left of the infrarenal aorta and usually crosses anterior to it to drain into the splenic vein behind the pancreas.
The complex convergence behind the pancreas.
Yeah. The portal vein itself is formed by the confluence, the joining of the splenic vein and the SMV, usually around the L2 vertebral level behind the pancreatic neck. It then courses superiorly upwards towards the liver within the gastrohepatic ligament, hepatoduodenal ligament part.
Within the portal triad again.
Right, with the hepatic artery usually lateral or slightly anterior to it, and the common bile duct anterior and often slightly lateral to it.
Okay, how do you access it?
A subcostal incision extending to the right flank or a midline incision is typically used. After dividing the falciform ligament, the right lobe of the liver is retracted superiorly and the hepatic flexure of the colon inferiorly, following a partial Kocher maneuver.
Mobilizing the duodenum again.
The first and second parts of the duodenum are mobilized and retracted inferiorly and slightly to the left to expose the structures within the porta hepatis. The portal vein is the most posterior structure within this ligament.
Furthest back.
And it's best isolated by making a longitudinal incision in the peritoneum on its right posterior aspect to avoid injury to the common bile duct, which is more anterior and lateral. Once the sides of the vein are freed, the common bile duct can be gently retracted superiorly and to the left to improve visualization of the portal vein.
Carefully separating duct from vein.
And again, a replaced right hepatic artery, if present, will usually run parallel and to the right of the portal vein and must be carefully preserved. Mobilizing the portal vein itself, from the pancreas up to its division within the liver, can be accomplished by carefully isolating and dividing its smaller tributary veins, which usually enter laterally and posteriorly.
Freeing it up by dividing side branches.
Retracting the right lobe of the liver by dividing its triangular ligament and applying gentle anterior and inferior traction with laparotomy pads packed posteriorly greatly enhances access to the porta hepatis. Uncontrollable hemorrhage from this region or from the liver itself.
The dreaded complication.
Can often be managed, at least temporarily, by inserting a finger through the foramen of Winslow behind the portal triad and compressing the entire porta hepatis between the thumb and index finger.
The Pringle maneuver.
Exactly. A critical technique for temporarily controlling blood flow to the liver, buying time to find and fix the source of bleeding.
The Pringle maneuver is such a vital technique in liver and portal vein surgery for achieving that temporary vascular control and managing significant hemorrhage. It highlights the crucial understanding of blood flow dynamics in this very vascular region.
Absolutely. Exposure of the superior mesenteric vein, the SMV, is similar to that of the SMA, its arterial counterpart.
Since they run side by side.
Right. After elevating the transverse mesocolon to visualize the root of the mesentery, the small bowel is retracted inferiorly and the SMA is palpated. The SMV lies immediately to its right.
Relatively straightforward access in the mesentery route.
The splenic vein is most directly accessed through the lesser sac, like the proximal splenic artery. A subcostal incision extending to the left or a midline incision can be used. After entering the peritoneal cavity, the lesser sac is entered by dividing the gastrocolic ligament.
Below the stomach.
The greater curvature of the stomach is elevated, and the inferior border of the pancreas is exposed. The splenic vein is then dissected along this inferior border, running posterior to the pancreas body. It receives numerous small tributary veins, making the dissection somewhat meticulous, requires care. This approach is useful for creating certain types of shunts, like distal splenorenal shunts for portal hypertension.
Okay.
The splenic vein can also be accessed inferior to the transverse mesocolon, similar to how we described accessing the left renal artery using the inframesocolic approach.
Coming from below again.
Right. The transverse colon is elevated, the small bowel retracted to the patient's right. The ligament of Treitz is divided, mobilizing the duodenum to the right. The left renal vein is identified as a landmark. The inferior border of the pancreas is located, and the inferior mesenteric vein, the IMV, running along the left side of the aorta, is traced superiorly up to its junction with the splenic vein, which usually happens behind the pancreas. The inferior border of the pancreas is then rotated superiorly, upwards, to expose the splenic vein running along its posterior surface.
Tracing the IMV up to find the splenic vein, another useful technique. The different approaches to the splenic vein again illustrate how surgical technique adapts to the specific anatomical relationships and the intended surgical goals,
Right.
whether it's creating a shunt between the splenic vein and the renal vein, or simply gaining adequate exposure for other reasons.
Wow, that truly was a deep dive into an incredibly complex area. Just amazing detail.
It really is intricate anatomy.
To quickly recap, we've seen the remarkable complexity of the abdominal vascular anatomy, arteries and veins, and the wide array of surgical approaches, the different incisions and maneuvers required to access it safely.
Yeah.
It's clear that a surgeon needs not only a profound, detailed knowledge of anatomy, but also the skill to navigate potential variations, those replaced arteries, duplicated veins.
And an understanding of the vital role of those collateral pathways, the backup routes.
Exactly.
What's truly remarkable, I think, is how these detailed surgical exposures underscore the body's inherent adaptability and resilience.
How so?
Well, the interconnectedness of the vascular system, with its multiple layers of redundancy and alternative routes for blood flow, allows surgeons to intervene in complex situations, ligating vessels, reconstructing them, while often minimizing the risk of widespread tissue damage because the body finds ways to compensate.
That's a great point. The body's built-in backups. This leads us to a thought-provoking final question for you, our listener. Considering this extraordinarily intricate network of blood vessels all packed into the abdomen and the sheer number of surgical routes developed to reach them, what does this reveal about the body's innate capacity to adapt, its resilience, and perhaps the ingenuity of the surgical techniques developed in response over decades?
It's something to ponder, isn't it?
Yeah.
The constant interplay between anatomical complexity and surgical innovation.
Absolutely. And with that thought in mind, if you found this deep dive into abdominal vascular exposures as compelling as we did, we encourage you to perhaps explore the specific chapters within sources like Rutherford's Vascular Surgery that detail these techniques, or maybe delve into related research within the constantly advancing field of vascular surgery.
There's always more to learn, always new refinements happening.
For sure. There's always more to uncover beneath the surface.